Hello, Paul.
Hi, Balaji, can you hear me?
Yes, Bridge.
You're on the TUGS logo, are you? Yeah, I'm on the TUGS logo. Yes.
Perfect.
I've logged in as TUGS. Excellent. So I've received your presentation. What I'll do is, first of all, I'll make you the co-host. There you go.
Hey, Balaji, how are you?
I'm very well, Paul. How are you? Gosh,
Good,
you're in a
thank you.
posh background setting.
Paul is always in theater.
I'm here again.
Yeah.
I know, yeah.
Is the
Paul,
sun shining where you are?
Where Balaji is.
No, where you are. It looks very nice outside. I can't see where Balaji's just got a white background.
The Balaji is, I think
Yes,
he's somewhere nice and sunny. I'm just in my conservatory. So that's the only place I can find some peace and quiet in my house.
It does look very nice.
Oh, thank you.
I thought you had a Nissan hut in your garden.
A what hut? That's the background, Paul, there.
Nissan
Oh,
hut.
wow.
Yeah.
Oh, beautiful. Look at that.
Yeah.
Fantastic.
Is that Aerostudy Park?
No, not Aerostudy Park, but it's a valley. It's I think it's the Amber Valley, I think, or one of those.
Okay.
It's a
Very
farm
nice.
there. Yeah.
Very nice.
So yeah, this is the only place I can find some peace and quiet in the house.
They've not got plans to build 400 houses there yet, then.
Hope not. That's not the plan. Don't know. So I've made both of you co-host. I don't know if you want to
shall I try?
see. Yeah, please try and share screen, Balaji, and then.
Yes, I'm just trying to. I'll share mine first. Let's see. Yes, I can see that.
Yeah,
I think it is being shared.
we can. Yes.
Are you in India then, Balaji?
No, I'm in Devon now, Paul.
Devon?
Yeah.
What are you doing there?
We came out for a week. Came out for a week on holiday.
Is it nice weather?
Not today, so that's okay. I've been at home all day. It's been reasonably good for the past few days, and we're leaving back tomorrow.
Good. It's nice to get away, isn't it?
So, yeah, absolutely. Madness. So we can see the screen, isn't it? So we're okay
Yes.
with that?
Yeah. So I think
I like your title.
Yeah, I mean, I've kept it mainly to just the pre-op decision making. It's just the basic stuff.
Well, I think that's
let's see.
That's what we want. I think if we get the basics right, I think it's half the battle won.
So let's see.
Paul, do you want to try and see as well?
Yes.
Balaji, if you stop screen share just for a minute, yeah. Paul, do you want to try yours? See if yours.
Oh,
we've got Varsha there. Hi, Varsha.
Hi, Balaji. How are you?
Hang on, where's that?
Good.
Let me just close down some of these other screens. There we go. How about that? Share screen. That one. Oh.
There we go. We've got it.
Does that work?
Yes, it does. Fantastic.
Can you see that?
Yeah, we can.
And you can still hear me as well.
Yes, we can still hear you as well. It's working beautifully. Nice. Thanks, Paul. Thank you. So, Vasha has joined us. Hi, Vasha.
Hi, how are you?
Hi, I'm very well. Yeah, I'll make you co-host too.
Thanks.
2 minutes if this works.
We've got Emily and Mustafa. Hello.
Yeah.
Hi.
Yeah. Hi, Emily.
All right.
Thanks for joining. Yeah, I'll make you co-host too, Emily. And if you want to just have a quick trial run, if you can show us your slides.
Okay. So if I just click share screen.
Yeah, you should be able to. I'll just say hello to Mustafa there. Hi, Mustafa. Thanks for joining.
Hi. Thank you so much. Sorry, I'm in my holidays. That's why I'm.
I'm so sorry.
I'm joined from my iPhone.
Oh no! So you are on holidays. Balaji is on holidays, and I think Vish is on holidays too. So really appreciate all three of you
Thank you
joining,
so much.
especially when you're away. Thank you so much.
Of course. Thank you so much for the invitation. Pleasure.
Thank you. Emily, that's working beautifully. We
That's
can
fine.
see it
Okay,
nicely.
let me
Thank you.
Stop sharing. Sorry, my Zoom's been a bit funny. Oh, here we go. Stop share at the bottom, isn't it? There we go.
Yeah. Excellent. So we've done all trial runs. We'll wait for a few more minutes.
Yep.
All right.
Hello, Kamal. Kamal's just joined as well.
Yeah, Kamal's joined in. Hi, Kamal.
Hello, Balaji. Hello, everybody.
Hi, Kamal.
Hi there. Hi, Emily.
Hey, Paul, you're right. Paul, are you really in theatre, or are you just making yourself look like you're working hard?
Hello, Paul. Hello, Vasha.
Hi. I'm not really in theatre.
Yeah, good background.
I thought you were faking it, yeah.
I'm lying on a beach at the moment.
Only.
That would be nice, wouldn't it?
No, especially in this rain.
So how many people are you expecting then, Bridge?
Just over 100, I think. Since we did this, I think we have about 750 registered for this meeting. That is for the rolling one. And there are about 60 registered just for this meeting, since we advertised it. So generally we have about 100 odd people joining.
Very good.
Yeah. And you'll see that it'll be, number of people from different countries. As we can already see quite a few joining in. And this is being recorded, so I'll announce that when we start the meeting as well, and we will then put it on the TUGS YouTube channel. So all your presentations and things will be available for if somebody can't join. Already a few people have emailed me they can't because it's midnight in India and quite late in Middle East as well. So they can then join it later on. Yeah, view it later on.
Well, it's brilliant to have that opportunity, isn't it?
It is, yeah. This is just, I think this is our 6th meeting, Paul, so far.
Yeah.
We started it in March, and yeah, I think it's been quite successful. And generally the feedback is quite good too.
Do you have sponsorship to be able to sort this out?
No, we don't as of now. So what Kamal has kindly done is he has paid for the Zoom subscription for us to have this meeting. For now, and I think hopefully eventually we'll sort the finances out. But as of now, no, Kamal has kindly offered to pay for it.
That's very generous.
Paul, I'll just comment there. The cost is not much, Paul. There, in total for the website and everything else, it's not even £100 per month. It's just that we're being slightly cautious here, Paul, with involving corporates, because you know well that doesn't come for free, and they always want something in return. And we've got significant leverage with 2,000 plus members at the moment, 2150 members from more than 100 countries. So we're going to set up a structure which will probably be a UK-based charity, and then that charity and the trustees can decide the future direction of the organization. So I kind of didn't want to commit ourselves to a course before that official sort of structure sort of formed. So that's why the hesitation to take money from anybody, Paul, at this stage. But it's not much really at all. It's less than £100 a month.
I think it's an amazing endeavour, really, and a lot of societies can learn from you. I think just to be that successful and have it free and available to anyone and everyone, I think is incredible.
It's a team effort, Paul, as you can see, really, and TUGS Lounge is particularly being run by Bridge from the beginning, and it does everything related to it. And likewise, the number of other things happening which other colleagues and friends are doing, really. So somebody's called it the Facebook of surgical societies. I think so I think it's kind of flattering to hear that, but we'll see how it goes, and the number of very well-meaning colleagues and friends on board. And I think so far we're leading by integrity and honesty. An example, we'll see how long that continues, to be honest, Hopefully it will.
Yeah, I hope it does.
Yeah. Likewise. Well, we mustn't steal Bridget's thunder. So
No. This it's everybody's show. So I'll just wait a couple more minutes before we start.
I'll mute myself and I'll turn my video off.
And I'm just waiting for Vish to join. He's also on holidays, but he said he'll join in. So.
And Bridge, about 20 minutes is okay, 15 to 20?
Yeah, I think that's perfect. Yeah, thanks, Balaji. That'll be excellent.
I've got quite a few slides, but they're all quite a running thing. No details in any of them. So
yeah, no.
Are you sort of comparing the questions, or do we just go on chat and see what people are asking?
So I've got Vesha, both of us will keep an eye on the chat function, and we will keep a note of any questions that come through the chat function, and then we will, okay. So, but feel free, if you see anything, any particular question that is addressed to you, you want to answer on the chat function, that's fine, Paul, as well. Quite an informal sort of setting we have. So that's not a problem at all. But we will try to keep track of all the questions that come through.
Okay.
Yep.
I'll mute myself.
Yeah, that's fine.
I think I'm going.
Okay, so I think we'll make a start, and I'm sure anybody can join in later on as well. We're just 8 o'clock now. So welcome everybody to the TUGS Lounge session on the 5th of August today. We are going to discuss a really interesting topic. I'm sure all of us will find it useful in our clinical practice, is decision making in primary and revisional anti-reflux surgery. So we have some esteemed speakers with us today, and I'm joined with Vasha Kaur, who is my co-moderator, and we are also really fortunate to have some experts with us today. So Vasha is a senior trainee. She's a senior registrar in London Deanery with special interest in benign apogee and bariatric surgery.
Hi.
Vasha, hi, Vasha. Thanks for joining today. Vasha, I'll let you introduce our speakers briefly, and then we can make a start, and the experts as well.
Yeah, of course. Thanks, Rich. So we have two presenters today, this evening, both upper GI consultants with interest in anti-reflux surgery. So we're very lucky to have them both. We've got Mr. Balaji, who's a consultant upper GI surgeon at Stoke, who will be speaking to us about primary anti-reflux surgery, and Mr. Leader, who's a consultant upper GI surgeon at Derby, who will be discussing revisional surgery with us. We're also very lucky to have equally eminent panel, Dr. Emily Tucker, who's a consultant gastroenterologist at Derby, who has prepared a mini benign upper GI MDT for us that we can discuss some interesting cases with, as well as Dr. Mustafa Al-Shafi, who's a consultant at Frankfurt, making this a very international meeting, a national evening for us, and Prof. Vishwanath, of course. So I was hoping we could maybe start with Balaji.
Yeah. Balaji, I think you're on mute, and
yes,
yeah.
So I should just kick off, isn't it? Yeah.
Yeah, I'll just say hello to Professor Vishwanath. He's just joined us as well. Hi, Vish. Thanks for joining.
Hi. Thank you. Good evening, all.
Good evening. Good evening. Right, so I'm just going to share my screen.
Please.
Yes, let me. Okay. I'm sorry. Getting Right. Good evening, everybody. Thank you very much for all attending the TUGS Lounge program this evening, and thanks to the TUGS committee for inviting us to, be a part of this August group. My name is Balaji, and I'm an Apogee surgeon, benign Apogee and bariatric surgeon at Stoke. And my interest in esophageal diseases dates back to my research fellowship with Tom DeMeester, and this was 20 years ago, and I've just not looked back. And I've had the opportunity to work with, I was a trainee under Paul at Derby, and Bridge and I, we were colleagues together. So it's an August gathering, and I'm very privileged to be here. My interests are into revisional bariatric and revisional anti-reflux surgery. And today, the topic is going to be decision-making in primary anti-reflux surgery. I'm going to stick to the selection process prior to surgery, not getting much into any sort of technicalities, and we'll try to keep it simple and stupid. So the decision is to do or not to do. And that is sounding simple, but not an easy one. Start with some aphorisms, love aphorisms. A good surgeon knows how to operate, and I suspect after a training program, wherever we've been, we would be expected to know how to operate. A better surgeon knows when to operate. This comes in over time, and the best one knows when not to operate. And the common crux here is the decision making. So this fits in so well. Another one, this is more so common the oncology side of things. They say the technical skills is the prince. Yeah, you might do, you might take 101 lymph nodes, you might do it using robo, you might using it endoscopically, laparoscopically, whatever. But the important thing is the selection for surgery. And whatever you do, the king and queen rule. So why are we talking about these thoughts on surgery? Undoubtedly, surgery is always more invasive than non-surgical methods. It's usually irreversible, or at least we do them. We do these surgeries not with an intention to reverse. Sometimes it's ineffective, we all know that. Unfortunately, sometimes it's inappropriate and not, it is all known that it's rarely infuriating for the patient, for the operating surgeon, for the surgeon whom the patients land up into, and sometimes the GP, because these patients are stuck with him or her for life. So with this in the background, I will go with two sorts of clinical scenarios, which we as upper GI surgeons commonly see in the clinic. The first patient with symptomatic reflux, who has been referred for anti-reflux surgery or sees you with symptoms of reflux. And the other big thing is the hiatal hernia patient. So I'll try to base my talk based on these two scenarios. The first patient with reflux comes into their clinic and says, "Doc, I've got acid problems. I've had this for a long time, and I want to talk about surgery." Or he says, "My GP thinks I've got reflux problems," or not infrequently, our other colleagues, our ENT colleagues, our cardiology colleagues, our gastroenterology colleagues, brand a group of symptoms of reflux, and they send them to the upper GI surgeon saying, "You need an operation for your reflux, off you go there." So what do they mean by this reflux? Symptoms of reflux. It's interesting. One of the first questions I ask is, what do you mean by reflux? What do you mean by acid problem? And they look at me like, what the hell are you talking about? And I say, yes, please tell me what do you mean by reflux? And some say, I've got acid problem. So, okay, what does it actually do to you? So just dissect into those questions. Heartburn. You'll be interested in seeing how many patients have different versions of heartburn. I've had infrequent or not infrequent saying, I've got pain in the tummy, and they suggest that as heartburn. So it's just dissect deep into the symptoms. Same thing with regurgitation. Where does it come up from, and how does it taste? Is it acid regurgitation, non-acid regurgitation? Is it just slushing in the esophagus? So killing the details is the key. Dysphagia is not a common symptom, although branded as a typical one for reflux disease or esophageal diseases, but that can also vary. You get people saying it's getting stuck in the middle of the chest, something in the throat, some sensation of choking. So dissect deep into the symptoms. And on top of this, we've got the combination of chest pain, epigastric pain, throat issues, cough, asthma, change in voice, recurrent chest infections, and they all come into this category when the patient is seen in the clinic. An important one, always ask for relief of symptoms with PPIs. It is a good test, not necessarily diagnosing reflux disease, but that there might be an underlying problem potentiating reflux disease. This slide is something I've been showing for the past 20 years since my research days. I think I've stolen it off Dr. de Meester, and he always puts this slide. The symptoms are all a combination of when these three tires go wrong. It's the esophageal pump, the anti-reflux barrier mechanism, and the stomach reservoir. And importantly, please beware of the guy who has got bloating, the one who comes into the clinic belching. Interestingly, you get some patients coming and just pressing up there and they belch, and they think, okay, this is something, just take a big step back. I've practiced for a few years in India, and I've come with patients requesting surgery, and they press their knees and they belch, and you think, wow, okay. And this patient's been referred for surgery. And beware of the non-responder with PPIs. Obviously, get into alarm symptoms to rule out more, concerning underlying neoplastic causes. Investigations, the MOT, the triple testing, we all put them through Apogee Endoscopy, plus or minus barium swallow, depending on one's preference, availability, and esophageal studies. I think we should keep them as comprehensive as possible and as necessary. Complementary investigations only when needed, like the CT scan, gastric emptying studies, and any other neoplastic potentials down there. Apogee endoscopy. It is not the workhorse of investigations in benign esophageal disease. It looks only at the inside of the esophagus. It detects complications, injuries, and other pathology, but it is, endoscopy is not all. We all know that. It does not diagnose reflux disease. It is about, it detects the complications. And we know that in over 50% of patients who end up having a diagnosis of gastroesophageal reflux disease, objectively, over 50% have a completely normal endoscopy. They fall into that criteria of non-erosive reflux disease. What can you see? What do you look for? Obviously, in the esophagus, you look for different levels of esophagitis, the presence of absence of Barrett's esophagus. And as you go down to the OG junction, you look at the presence or absence of any stricture, cancer. And at the OG junction, I think we all have to spend time at the OG junction looking at certain landmarks, identify the OG junction, identify the squamocolumnar junction or the Z line, measure hiatal hernias, and assess the gastroesophageal valve by the retroflux maneuver, which is the Hill's grade. These are immense things which we have to look at as people who are looking for a surgical option here. Barium swallow, an underappreciated tool, useful to immense levels of information, and it offers a roadmap to pathology. I think it gives a lot of information which is not seen by endoscopy or CT scan or anything else. Look at these things. For example, this picture, you cannot reproduce that in any other CT endoscopy, no. This one, the one on the bottom right, is an impression of the left atrium. I can't think of any other investigation which would show that. And understandably, your hiatal hernias at varying degrees of complexity, it helps you plan an operation, not necessarily for straightforward reflux, but with these large paraesophageal hernias, a barium swallow just allows you to plan. GI physiology studies, I personally feel that it's essential in all patients when we are considering a surgical option. Hose up the nose test, they always help. What do we do? It's a pressure recording of the pressure profile during swallowing in the esophageal lumen and the region of the hiatus / lower esophageal sphincter zone. These days, it's also compounded by the presence of impedance studies, which can be a combined impedance and manometric profile. That's your high resolution manometry. I'm not going into any details. I think most of us have the facility to perform high resolution manometry, catheter based ambulatory pH monitoring plus or minus impedance. Most of the units do have catheter-based rather than catheterless Bravo system, but I feel these are imperative. That's the catheterless system, the Bravo capsule, which measures the impedance without, measures the pH monitoring without a catheter. And then you either get the reading as normal when you have some reflux episodes, upright reflux with the supine period with no reflux at all, and bipositional reflux. And this is an old slide with the standard pH analysis, but then these days we've got impedance studies, we've got combined pH impedance, but parameters we look at is the AET, which is the acid exposure time, plus or minus diminished score, and the NRE, or the number of reflux episodes as well. Two recent things which have come up, although not very recent, the Lyon consensus summary, which happened in 2018, looking at definitions and the investigations which are necessary, they have come up with these, the top end is the conclusive evidence of reflux with pH or impedance with an acid exposure time, endoscopic esophagitis C and D, and on the other end is against reflux with no reflux episodes, which are pathological, or an acid exposure time less than 4%. And this in between does form a group. You get these borderline here and there, and that's when we've got to take in other parameters into consideration. In 2020, I think it's just for mentioning the slide, don't look into any depths. There's been a recent Chicago classification of high resolution manometry, which has some changes with regards to classifying them generally into disorders of EGJ outflow and disorders of peristalsis. This is a slide which I've been putting for the past 20 years, and I still it holds the test of time. Predictors of success following anti-reflux surgery. A positive pH score, you can modify that to positive reflux monitoring, not necessarily acid reflux. It might be acid and non-acid. Typical symptoms and good response to medical treatment. I still think this holds the test of time. Those in between patients, not the straightforward positives or negative. The benign upper GI hiatal MDT is the ultimate investigation of choice. We do encounter a good group of patients which do not fit in what they're supposed to come in on all these tests. And that's where the MDT comes in to help ourselves define what we move forward. In Stoke, we've been running a benign upper GI / hiatal MDT for the past 3 years. It's done really well. I was so excited to hear that in Derby they've started as well, and we're going to have a session of that sort today. It is to weed out and identify what's best for these patients. It is not just about operating. It's about whom to operate and whom not to operate. Manometry and pH studies. We all know people who do studies all the time and don't do studies all the time. Or selectively. I feel that it would be appropriate in patients prior to anti-reflux surgery. The maximum information we have would help us define the potential outcomes and counseling the patient. Why do we do manometry? To rule out a primary motility disorder. Although very rare, we've all heard of that occasional patient who's had anti-reflux surgery and then found to have achalasia. Reflux is known to produce motility disorders or vice versa, such as connective tissue disorders. And for doing pH studies, you need to know where the LES is. So you do need a pH study. This would come out for discussion, but I personally feel GI physiology studies form a part of the workup towards surgery. In patients whom we're not planning surgery, we don't have to do these things. But prior to surgery, it's important. Indications for reflux, the crux. First of all, is to establish that they've got reflux disease. Once they've got reflux disease, then you've got subgroups of patients who would benefit from surgery. The patients who have failed medical management, I'll detail on that. In patients who've got successful medical management, in patients with complications and extraesophageal symptoms. Who are those who are the failed medical management? The patient who benefits but is not compliant, or needing escalating doses with reduction in the relief over time. The volume refluxes. The volume refluxes will continue to have non-acid reflux because the PPIs kill the acid, and intolerance to PPIs. Then in patients who've got established GERD and they're very happy with medications, but they're thinking about, reflux disease treatment is not a one-off thing. It's a lifelong process, in addition to your lifestyle management, reduction in weight and all that. In young patients, financial implication, patient choice, and quality of issues. And this is another slide which I'll be putting on again and again. The best surgical candidate is someone who responds to medications. Next one, which I'm passionate about, is hiatal hernias. We get our next patient coming into the clinic. Doctor, I've got a hiatal hernia and I think my symptoms are due to that, and my doctor feels that an operation would cure it. And then I go, oh my God, because they've come in with that branded thing. I've got a hiatal hernia and that's the cause of my symptoms and I need an operation. Quick one, sliding hiatal hernia, the commonest, where the OG junction slides up into the chest. The rolling hiatal hernia, which is usually a defect in the phrenosophageal membrane, and the OG junction is in the normal position, relatively rare. The mixed paraesophageal, which is not uncommon, and the type 4, which we've got all contents apart in addition to the stomach in the chest. Its association with reflux disease. Interestingly, the diagnosis of a sliding hiatal hernia is very variable. You look at different performers. I did an August survey last year to see how people define hiatal hernias, and you would think something as seemingly simple in the diagnosis of reflux disease, the hiatal hernia, would have some standardized, diagnostic measurements. There's so much variability in how people define the OG junction, the squamo-columnar junction, how they measure a hiatal hernia, and what choice they have in detecting a hiatal hernia. There's so much variability. And we talk about a 2 centimeter hiatal hernia. We know that even the markings within that endoscope is only 5 centimeters. And you make decisions based on a 2 centimeter hiatal hernia. So the hiatal hernia diagnosis needs further clarification. And the small hiatal hernia, how important it is. I'm sure you've all seen, and I've seen many over the years, endoscopists saying this patient has got a 7 centimeter hiatal hernia. And you go and do a barium swallow, there's nothing at all. And you do a laparoscopy, there's nothing at all. I've had patients saying this patient's got an intrathoracic stomach, she needs an urgent operation. And you look back and there's nothing at all. So there's so much variability. So always take that diagnosis of a hiatal hernia or an endoscopy, just look deeper. And they come in with these misconceptions not infrequently. The mere presence of a hiatal hernia on endoscopy means that the patient's got reflux disease, and it means they need an operation. Well, when I was doing my research 20 years ago, we did a study in about 50 normal volunteers with no evidence of, no symptoms of reflux, absolutely nothing at all. We did a barium swallow, upper GI endoscopy, both of these, and 40% of us had a small hiatal hernia between 2 to 3 centimeters, and I was one of them. I had my barium swallow repeated, interestingly, in the upside down posture last year for some research purposes, and I had a 3 to 4 centimeter hiatal hernia, and I've not had reflux, touch wood. I don't know what heartburn is. So it doesn't necessarily mean that I need an operation. I might have reflux. I've not had my latest pH manometry, but it's just mentioning that the importance of that label and myth regarding this hiatal hernia. However, in a patient with established reflux disease, the hiatal hernia is important because it can form that acid pocket, delayed clearance, and it increases the severity of, oops, it's gone down. It increases the severity of reflux disease in someone who's got GERD. So the treatment in the presence of objective reflux, treat the hernia as a part of reflux unless they are large and they have mechanical symptoms. Finished with that. However, I'm not a skeptic of anti-reflux surgery. In established GERD, anti-reflux surgery is a mechanical fix for a mechanical problem. This is a slide. You might be thinking I'm nicking all these slides from everybody. This is a slide from Lee Swanstrom, which when I was a researcher, I love this slide. And it is, in the right patient, it performs fantastically. Counseling is important. Beware of the non-responder to surgery. Beware of the bloater and belcher. I can't emphasize this enough. Managing expectations is very important. I have cancelled a patient last year on the day of surgery because bloating was her main symptoms, although she had significant reflux disease. And when I mentioned her bloating is going to get worse, she said, I don't want this operation because bloating is my main symptom. Explain the potential complications and the potential for symptoms to come back. I think we should be realistic in balancing this, but under promise and over deliver. There's no harm in scaring them. You're putting them through a lifelong, potentially intendedly irreversible procedures. They've got to know what it is. Principles of anti-reflux surgery: adequate height mobilization, dissection, get a good length of esophagus, appropriate crural repair with or without mesh, and an effective fundoplication. However, I think we all know as trainees and when we operate with colleagues, there are no two people who do the operation the same way. Starting from port position to the method of dissection to how we do certain variables, they're all different. So I think we can only standardize the principles of surgery. We cannot standardize every little step. And there's so much variability here. Special circumstances onto the type of fundoplication, the presence of motility disorders, and in the new era of links and endoscopic surgery. We do have long-term follow-up studies based on systematic reviews and meta-analysis. I think the overall take-home message is they're equally effective in reflux control, similar side effect profile, similar complications. We have various variables influencing the choice of surgery, something as valid as whom we trained under. Certain, we might have one patient who has put you off a partial fundoplication or a total fundoplication. And then over time you change. And it doesn't mean that one is bad or one is good. You select the patient well, you do the operation properly, and if they've got good outcomes, choose wisely. The word wise is a very simple term, but it's a very complex one there. And I think we should take all these into consideration there. Motility disorders and reflux disease, beware of the potential one with achalasia. Ineffective motility, whether it's due to reflux or reflux due to a motility disorder, rule out connective tissue disorders if applicable. And if they're all ruled out, we do offer patients with disordered motility anti-reflux surgery. And the key here is explaining the operation. We've all had patients whom have had motility disorders and we've offered operation and they've done fantastically well, and sometimes they've not. And it's striking the balance. What's their main symptom? Some come and say, I don't care about dysphagia, it's my reflux alone. So it's balance, it's the balancing act. The evidence is variable on tailoring the fundoplication based on motility. In the new era of endoscopic treatments, the Stretta and the transoral incision fundoplication, and we've got links as well. These have been around for a good few years. They've all been over there for 10 years, and we've got good studies establishing their efficacy and safety profile over the years. However, they do have limitations in terms of, they say, large hiatal hernias, anatomical disruptions, severe reflux, etc. And the availability is limited based on the expertise. And there is always a center of excellence or a surgeon of excellence bias. For example, if you go and look about links publications, all the best results are from John Lipham or Luigi Bonavina, who are the big centers. And similar on the other way. So always take them with a pinch of salt, look deeper, but they are here, they've stood the test of time, they're effective, and there are special needs for them to be, once again, considered wisely. In the new era of all this, whether you're a fast, super fast surgeon, super slow surgeon, robotic, laparoscopic, links, endoscopic, whether you're doing it in the NHS or private setup, the science is the same for now. It may change. The indications should also remain the same, and the patient should be the one on the other end of the table. So I would say the CCC recipe for decision making, a thorough consultation, dissect out the symptoms, look out for alarm flags, combination of investigations, and careful counseling of risk benefits. I think I'm done. Thank you very much.
Hi, that was great. Thank you very much. I think certainly covered a lot of ground as well in a very short time. So thanks very much. We've got a few questions, if you don't mind, and maybe yourself and the panel. First of all, by Richard Thompson, who's wondering what your thoughts were on anti-reflux surgery for patients with laryngopharyngeal symptoms rather than lower down, particularly people who say things like they can't swallow at this level, which I also find quite sometimes a bit difficult to manage. And what about your thoughts for hoarseness, cough,
Well,
and so on?
I mean, the symptom up here is usually a bit even any problem lower down, due to the referred nature, they come up with symptoms up there. So even if we've got our patients with EGJ obstruction, they come up with symptoms up in the throat or neck or so. But however, looking at extra esophageal symptoms in reflux disease, I think the key is get objective evidence. It's not just brand it as reflux. Get objective evidence. You can even go, the impedance is a fantastic way. You can look at the height of the reflux. You can see it shooting up into the pharynx. The barium swallow at times, you can see these reflux coming all the way up into the, up to the level of the clavicles. In these patients, I think surgery would help for sure. So I think the key is making sure they've got reflux, counsel them well, but I think it's always under promise, saying that the symptom relief might not be as good as the other ones, and it might take a relatively prolonged time to get better. But there are definite indications provided they're investigated well.
Yeah, I think Professor Vish is raising his hand. Vish, would you please comment on this?
Yeah, thank you. Mr. Balaji has presented excellent summary of two typical patients. From the point of the question, LPR, there's something new in the market called restic oropharyngeal pH probe, which is not sort of very well unknown to the not only UK perspective, even rest of the world. It's mainly North American driven. I do use it for LPR patients. Basically, besides the impedance, besides the barium swallow, in some patients where you can see the reflux rate almost touching the oropharynx or upper sphincter. This is a small catheter, transnasal, placed in the oropharynx, which is back of your throat, not into the esophagus. And the pH less than 6.5 in the throat, back of the throat, if it's positive, it basically patient has got a gastroesophageal reflux. So in patients without esophageal symptoms such as heartburn, regurgitation, they can present primarily, especially to the ENT colleagues, with what we call LPR symptoms. So a lot of these people, besides gastroenterologists, besides our own colleagues, but ENTs are the first mode of consultation. So I do get a lot many, and I do this restic pH. It's called RESTECH pH study. So certainly something which, before you embark on a patient with LPR towards an operation, this is a useful tool. Like Demister's son called Ryan Demister, who is my colleague. It's called Ryan score, RYAN. So I can talk about it later on, but yeah. So certainly, LPR symptoms, yes, LPR symptoms with combination of classical reflux, you do benefit. But as Mr. Balaji said, it's very important to counsel, and expectations has to be managed and always undersell it. So that's me. Thank you.
Yeah, no, thank you, Vish. Mustafa, can I ask your comment as well on laryngopharyngeal symptoms, and if you have any experience with the investigation that Vish was mentioning?
Yes, sure. Of course, great presentation. First of all, thank you so much. And I have two comments actually. First of all, regarding the measurement of the hernia, the gastroscopic measurement of the hernia, is for me a very, very important diagnostic tool, as I'm doing the gastroscopy myself. Regarding the extraesophageal symptoms for reflux, I agree for the physiological studies for the esophagus, but actually to reflect my real experience, practical experience, and I'm seeing like 120 patients per month, reflux patients. I can't afford for every patient the physiological studies, manometry and pH-metry. I'm relying on the clinical presentation. We have our questionnaire for all the patients, and relying on my gastroscopy, and every patient will get the barium swallow. So the barium swallow, for me, it's a replacement for the patients with a clear clinical presentation of reflux, either esophageal or also only extraesophageal symptoms regarding the hoarseness of voice or the other extraesophageal symptoms. So I'm relying mostly on my gastroscopy and on my barium swallow. And if I get from either of both a direct sign, clear sign for reflux or hiatal hernia, combining it with a clinical presentation and history of the patients, so I go for a surgery, either fundoplication or links. It's another topic. Maybe for extraesophageal symptoms, as I'm offering both of techniques, so I'm preferring the links implantation, as it's a physiological operation, and from the experience, it helps much more for those patients.
Excellent. Yeah. Thanks, Mustafa. Thanks for sharing that. I think there are a few more questions, but shall we move to the next presentation by Mr. Leader, please? And then we'll come back to these questions. Is that okay, Paul?
Yes, okay by me.
Yep. Thank you.
You ready for me to start?
I think so, yes. If you can share screen, Paul.
So, can everyone see that all right?
Yes.
Thanks ever so much for asking me to talk bridge. I'm just following on from Balaj's excellent presentation. We all know each other very, very well, and Emily's part of our MDT as well. So I'll be interested to hear what she's got to say in a few minutes. I'll be asked to talk about decision-making in revisional anti-reflux surgery. First to say, I don't have any disclosures, but I think, and I've been working as a hiatal surgeon for about 20-25 years now, and so I do have a lot of experience, and I think anyone will identify that when they've been operating on that area and performing anti-reflux surgery for many years, they will inevitably become an expert themselves at managing failed anti-reflux surgery. So these are the areas we're going to be covering. First of all, just talk about the incidence of anti-reflux surgery, look at the symptoms and the underlying causes of those symptoms, which I think is important to emphasize, look at what investigations we can do, and then finally what treatment options we have at the end. These are some outcomes of 10 and 20-year studies looking at anti-reflux surgery. And you see most people have between 80 and 90% what they record as satisfaction. So these are patients that are happy with the results of surgery. And I think the key at the top there really is that we're talking about clinical outcomes. It's really, really important just to think about the patient at the top of this. If you were to do studies radiologically of these patients, you will find a completely different group. That there will be a lot of recurrent hiatal hernias, and the majority of these are completely asymptomatic. So we're not talking about those at all. We're just talking about clinical failure. Both these studies show a degree of quite a significant number of complications and side effects from surgery. And you see in the top study, there's about a 5% reoperation rate. And most studies looking at long-term results of anti-reflux surgery would show that they're reoperating on about 1 in 20 patients. I think that's fairly standard for any practice. What are the dominating symptoms? So unsurprisingly, there's a lot of recurrent reflux. This can be either persistent or coming on classically probably about 2 or 3 years after the initial surgery. And about half of the patients present with reflux. The next group are those patients with significant dysphagia, most commonly persistent immediately after the operation, more unusually developing at a later stage. There's an interesting group of patients that actually have reflux and dysphagia, and it's often very difficult to pinpoint exactly what the primary problem is there. And you're thinking, have they got a loose wrap or an overly tight wrap? Can they have a bit of both? And it's they're a very difficult group to deal with. And finally, there are those with gastric symptoms, predominantly problems like gas bloat. Following on from Balaji's talk, really, so this is a classification of the different groups of patients. The big group we have to look at the top, really, is the wrong patient. These are the patients that shouldn't have had anti-reflux surgery in the first place. Maybe that this was a wrong decision making or the investigations are wrong. The most common group that people worry about are those with undiagnosed achalasia. There may be that the patient did genuinely have reflux, but perhaps had the wrong operation, and that's another area to be looking at. If they had the right operation, maybe it worked initially and failed later on, or maybe that they're having side effects straight away from the surgery that just are failing to settle. So we're going to classify the different most common complications. So first of all, we'll talk about recurrent reflux. And with all these classifications, they're either the anatomical abnormalities or other potential causes. So anatomically, it could be that the wrap was formed initially, it was just too loose right from day one, and it should have been tighter. More commonly, the wrap was initially very good, but over a period of time, the hiatal repair or the wrap may loosen, and the integrity of the anti-reflux barrier will break down over a period of time. More commonly that I see in my practice is development of paraesophageal hiatus hernia, and that can develop, can cause reflux long term. Other causes we need to always think about are eosinophilic esophagitis, which is quite de rigueur at the moment. And interestingly, there's another group of supragastric reflux where they don't actually have genuine reflux at all. It may be that they have an over-tight esophagogastric obstruction, and all they're experiencing is excessive pooling of fluid in their esophagus that the patient may be describing as reflux, but they don't actually have proper gastroesophageal reflux. Dysphagia is the other group. Anatomically, this may be a problem relating to the wrap itself, and I'll show you a diagram of those conditions in a moment. Also, it may be related to a stricture at the hiatus, and this can either be that the hiatal repair is too tight or maybe scarring forms later on. We also have to think about other causes. We've already mentioned achalasia, but there are other motility problems with peristalsis that can cause dysphagia postoperatively. And we also have to think of other problems associated with cancer or, again, eosinophilic esophagitis. This is a good classification of the different wrap failures. So type 1A is the dreaded complete wrap herniation into the chest. We always worry about this, particularly acutely, as that can become ischemic and is potentially life-threatening. More commonly and perhaps chronically is a type 1B, where the gastric cardia can slide up through the wrap into the chest, and that can cause, again, a combination of reflux or dysphagia. The type 2 is the paraesophageal hernia that we mentioned earlier. And type 3 is an inappropriately formed wrap at the beginning. So in this type of condition, the first surgeon used the gastric body rather than the gastric fundus to form the wrap. And finally, what about gastric symptoms? So again, I mentioned these mainly symptoms of excess wind, bloating, gas bloat. Anatomically, it may be due to a vagal injury at the initial surgery or other pre-existing gastroparesis, most commonly in patients with diabetes. Or maybe you're looking at other problems such as irritable bowel or even small intestinal bacterial overgrowth. And all these things need to be looked at separately. So again, reiterating Balaji's talk, I think the most important thing is take a really detailed history. So whenever I see one of these patients in clinic, I always book a double slot and sit down and go through their history, all their symptoms in fine detail. And that way you can try and pinpoint exactly what the problem is and how it's affecting their quality of life, because that's the most important thing. This is quality of life surgery that we're doing. And really that's the key factor. Again, they're listing the different investigations. A lot of people will do these for first-time surgery, but these are particularly important when you're looking at revision surgery. So we'll go through those in more detail. A barium swallow, I think, is very, very useful to define anatomy. This is a recent patient I admit to. One of my paraesophageal hernias from about 5 years ago has recently come back with recurrent reflux. And unfortunately, they developed another hernia. The key to looking at barium studies is identifying where the diaphragm is. Once you know where the diaphragm is, you can assess exactly where the stomach is in relation to the diaphragm. If they have developed a significant hernia, you may want to arrange further imaging, such as a CT scan, where you can assess the size and position of the hernia, and you're also looking for other factors, so the typical type 4 hernia with either transverse colon or omentum included in the hernia itself, which can't be identified on barium. I think endoscopy is imperative, and what I would always recommend that if you are revising patients, you need to do the endoscopy yourself. Do not rely on a report from some elsewhere. It's really important that you do a J maneuver to look very carefully at that hiatus in fine detail. This is a typical view of the correct position for a Nissen fundoplication. In anterior partial wrap, this is a typical view with the accentuation of the angle of His. Again, another one of my patients here that you see on the retro, the reverse J maneuver view, you can see slight loosening of the wrap around the scope, but typically this is a paraesophageal hiatus hernia that's fairly obvious on retroflexion. pH studies are useful, I think, particularly if you're trying to identify or confirm the presence of reflux. If they do have abnormal levels of reflux, then that is confirmed. If the pH study is completely normal, then it may be that they have that supragastric reflux that we mentioned earlier, secondary to an esophagogastric obstruction. Manometry, I think, is key. I don't think you can get away with just doing a barium study. You're looking particularly for impaired clearance, poor peristalsis in these patients, looking for that group of patients that may have had an incorrect diagnosis, and looking in fine detail at the esophagogastric junction. So you may be able to identify an over-tight wrap, over-tight hiatus that fail to relax during swallowing, and also look for the possible hiatal hernias. And also can be useful looking delayed gastric emptying as well as gastric scintigraphy. It's the typical manometry. I'm sure Emily will be showing lots more of these pictures. You can see the lower esophageal sphincter at this point, the high pressure zone, but lower down, there's the diaphragm moving with respiration, and so the area in between represents a recurrent hiatus hernia. What are the treatment options? So this is a fairly classic established view on this. So if they've got recurrent reflux, I think it's really important to try and maximize medical therapy. They don't all require revision surgery. So look at Acid suppression, get your gastroenterologist involved here as well. Look at prokinetics, look at other symptom control, but probably about 50% if the symptoms are persistent may require reoperation. Persistent dysphagia is a more difficult problem. If they are identified to have a tight hiatus, then that may respond to esophageal dilatation. But unfortunately, more likely, an over-tight wrap is really not going to respond to dilatation, and really you're looking at reoperation in that group of patients. If the wrong diagnosis was made, particularly if the patient has achalasia, then I'm afraid it means that you have to take down the wrap completely. And a paraesophageal hernia most likely will end up requiring revision Hiatal surgery. What type of operation are you going to do? So most of these patients, and certainly my hands patients, will require redo fundoplication. We'll discuss whether you want to go for a full or partial wrap. All hiatal surgery really is what works best in your hands. And I think if you're in a unit that performs laparoscopy, then that would be the procedure of choice. There's no negativity with doing them as open procedures, and certainly the more revisions are required, the more likely to require open or even as a thoracotomy procedure. And more recently, some surgeons are starting to do this robotically. So whatever works best in your hands and is available to you in your unit. Colles gastroplasty is interesting. I wouldn't normally do that for the first revision, but maybe subsequent revisions. The underlying problem may be a short esophagus, and there have been some good reports, and we've done it a few times in Derby, of doing a laparoscopic wedge Colles gastroplasty for this group of patients that can work in individual cases. Gastropexy has been reported, particularly for patients with poor peristalsis. I've not used it myself just on its own, but some units do advocate it. We will discuss in a moment about the option of Roux-en-Y gastric bypass as an option. And as a last ditch failed, if all else fails, then we always have esophagectomy. This is a good systematic review of re-interventions after failed anti-reflux surgery. It's worth looking at. So they looked at over 4,500 patients reoperation. They identified a 78% success rate, which fits very well with the outcomes we normally discuss. Whenever I see a patient, I normally state 90% success rate with first operation, 75% success rate with second operation, and about 50% success rate with third operation. And it deteriorates more operations you perform. I think the important thing to note here is there is a significant complication rate, and that should be part of your decision-making process with your patient. And some people die from this surgery, so that's really, really important to be aware of. What are those complications? This is another interesting study looking at the most serious complications, and the incidence go up the more revisions are carried out. So if you look at when you get to your second or even third revision, the incidence of vagal injury goes up to over 50%. So these are all things you need to be discussing with your patients. What about BMI? So we mentioned about patient factors. So there is very good evidence, and we all feel this in our heart of hearts, that the incidence of recurrence was down to the patient, not us. And this is good evidence. Patient with a higher BMI is far more likely to get a recurrent hiatal hernia, up to over 70%. So some people advocate doing something else rather than redoing the same thing over and over again. Maybe we ought to be looking at a Roux-en-Y gastric bypass in this group of patients. So there's interesting studies looking at this that do advocate that a Roux-en-Y gastric bypass is a reasonable option for the obese patient, and it's particularly useful as an option in post-surgical gastroparesis with vagal injury, that people can get a good response, and satisfactory outcomes have been reported. In Derby, we did arrange an audit a few years ago of all UK upper GI surgeons, and found that 80% stated that Roux-en-Y gastric bypass was their preferred option for management of reflux with a BMI over 40. I know a lot of US surgeons advocate BMI 35 plus, but that's a significant group of our patients now. That's the average weight in Derbyshire. So short of adding to our bariatric waiting list, I think we still need to be doing fundoplications on some of those patients. Should be using mesh for your hiatal repair. This is a really good meta-analysis looking at the difference between suture and mesh repair to augment your hiatal repair. It looked at 7 randomized controlled trials. There is no difference in short, long-term recurrence, functional outcomes, or patient satisfaction. So whether you use mesh or not, it doesn't make any difference at all. And anecdotally, I've started using mesh less and less in my patient group. Just briefly, we'll just go through what you need to do. I would advocate full mobilization. I think you need to take down the wrap that was originally formed, take it down completely using sharp dissection, try and use heat source as little as possible to avoid injury. The key to it is mediastinal dissection, just to ensure you gain a good length of intra-abdominal esophagus. And although I don't always take short gastrics down with first surgery, I think with subsequent surgery, I think that is a useful thing to do, just to gain as much length and mobility as possible. Then you look at hiatal repair. You need to assess the hiatus, make sure the tissues are strong, repair the hiatus posteriorly, and more people now are including anterior sutures, which I think is very, very important. If you do use mesh, I would advocate using biological mesh. There's some good synthetic biologicals out now, but it is important to use it as a U or reverse C type shape. Do not complete the circumference around the hiatus, because you're going to get a high incidence of stricturing, so don't do that. And then revise it to whichever wrap you feel most comfortable doing, whether it's a Nissen or a partial fundoplication. Here's an anterior partial. Which one do you choose? So I've already mentioned whichever one you're comfortable at, but this is the standard practice. I think most people would suggest that if there's normal peristalsis, you should be doing a redo Nissen. It sounds sensible. If there's poor peristalsis, maybe you should be choosing a partial, either a toupee or anterior partial, or even a gastropexy. The definition of poor peristalsis, Chicago classification is over 50% ineffective swallows, or a distal contractile integral of less than 500. That's something to be thinking about. What's the evidence of that? It's actually very little evidence. So this is a good study from Adelaide this year, looking at 10-year outcomes of fundoplication. This is a combination of Nissen and partial wraps in patient with completely absent contractility. And they found no difference between those with normal contractility, no difference in dysphagia or satisfaction scores at 10 years. Interesting. I suppose that fits in with the fact that we do wraps in patients following Heller's myotomy, and they seem to work very well. So it's very, very much in keeping with that ethos. Finally, looking at long-term outcomes. This is another Adelaide paper. I worked in Adelaide, so I'm obviously biased, but this is looking at 15 to 20-year outcomes of a randomized study looking at the difference between Nissen and anterior fundoplication. As we mentioned already, they all had very good outcomes. Long-term, still 90% satisfaction score. The most important thing here, I think, is looking at the revision rate. So in the anterior group, 6 patients, so it's around about 15% revision rate in this group. They all had reflux. So they had revisions for reflux, and they converted anteriors to Nissens. Sounds sensible. In the Nissen group, exactly the same incidence of revision, except most of those were for dysphagia. So in that group, if you got a Nissen, you get dysphagia, convert to an anterior partial. That all sounds very, very sensible. And I would advocate that as a way forward. Whether you accept that as good evidence or not is up to you. In summary, 50% of the failures are either due to a technical error at the original surgery or due to wrong patient selection. So as Balaji advocated, get it right first time. I think that's the most important takeaway message from this talk. If you do have to manage revisions, of course, all of these are not my patients. They're patients that come from elsewhere, none of mine, obviously, but take a good history, really, really important. They don't all require revision surgery. It's really, really important to discuss it in fine detail. If you do need to revise, make sure there's an anatomical abnormality that you are going to revise. These are complex operations that do have significant risks attached to them, and maybe this should be just for specialist centers, but that's something that we can discuss. That's all I was going to ask to talk about. Any questions at all? Feel free to ask. Thank you.
It was an excellent talk, Paul. Really, really well delivered. Thank you so much. Vasha, I think we have some questions before we go on to Emily's.
We do.
Yeah.
Thanks very much, Motility. We had a couple of questions, some following this and some following the first talk, and I'd be happy for anyone who can answer them. The first one was to do with what you would think about patients with bloating syndrome and whether you think a partial versus a full fundoplication, and also whether any other indications for partial versus a Nissen's fundo for these patients.
Most randomized trials do suggest that there's significantly less incidence of gas or wind-related symptoms early on, following a partial compared to a full wrap. If you look at long-term results, the difference really doesn't hold out for very much longer. So in my personal experience, I would suggest that if patients do have a lot of bloating as part of the decision-making process, I discuss the various options with patients and they normally will go for a partial wrap, but it's how you sell it, I suppose.
Yeah, thanks for that. In terms of patients who've had previous vagotomies and Billroth too, we've had a question about whether you would do anything different if someone comes in with Barrett's esophagus. It's quite a complex question.
Right. I mean, yeah. We can discuss this. I don't think there's a straightforward answer there.
Yeah.
So we say, okay, let's look at Billroth 2. Billroth 2 means, if I'm right, it's a loop gastrojejunostomy with a partial gastrectomy. And we've got Barrett's esophagus as well. So Barrett's esophagus, here we've got a combination of bile and acid. So would I be appropriate in suggesting, if we are going down the surgical route, it would be a Roux-en-Y gastric bypass. Either way you do it, whether it's laparoscopic or open. I mean, I think I've just started it off. I think the other panelists can add on.
I'd agree. I would do my best to avoid bile reflux. That significantly affects quality of life, and a Roux-en-Y works very well. The only other option, I suppose, is something like a one anastomosis type gastric bypass, where there's a significant length of gastric pouch, which hopefully will reduce the incidence of bile reflux. Kamal knows all about that.
Yeah, I just want to add, obviously, this particular patient with Barrett's, with reflux, with the Billroth too, if you've got Hiatal hernia, obviously you have to do a Recurrent Repair. And if they have not the first operation, if they have spared the short gastrics or the left gastric, you can do an anterior wrap associated with it. It entirely depends upon whether they've got volume reflux or not. But the most important thing is converting a loop gastrojejunostomy into a Roux-en-Y long elementary. So that's well said. Thank you.
Yeah. And on the topic of Roux-en-Y gastric bypass, and I know you've mentioned it briefly, we had a question earlier about high BMIs management and whether in primary surgery, whether you would consider going straight to Roux-en-Y gastric bypass rather than anti-reflux surgery.
I include that as part of my decision-making process with the patient. I ask them if their weight is troubling them. If they have weight-related comorbidities, then I often recommend a gastric bypass as an alternative for them. There is a group of patients where the weight is not an issue for them, and their primary aim for surgery is to control their reflux. And I think if they're in that BMI 30 to 40, as long as they are counselled about the recurrence rate, then I would normally still offer them anti-reflux surgery in that group. I think above 40, the recurrence rate is so high, I probably would push them more towards a Roman Y.
Excellent. I think, shall we move on to Emily's? I think a few of these things will be covered. To everybody, I'm conscious we are reaching 9 o'clock, but Dr. Emily Tucker is one of our colleagues in medical gastroenterology. She started the MDT at Derby, and she has put together some really interesting cases. So if we can finish maybe 10-15 minutes late, but if anybody has to leave, please feel free to do so. We will put the recording on the TUGS YouTube channel. Emily, thank you so much.
Okay, thank you, Bridge, for asking me to talk. I'm a gastroenterologist at Royal Derby Hospital. I've got a background in Apogee imaging in benign and functional disease, and part of that I did a lot of work with manometry and lots of work with pH and reflux as well. So I'm just going to briefly outline our Apogee MDTs. It's something we've only started recently, although it's obviously something that's occurring in other places as well. Sorry, wrong button. There we go. So we previously had a very informal meeting just between one upper GI surgeon, a gastroenterologist and a GI physiologist. Realised we needed something a bit more formal as decision-making regarding motility and reflux surgery became more complex with a complex and greater number of patients. So with COVID, it's a mix of face-to-face and MS Teams, which works quite well because people can join from wherever. We are playing for about once a month, but it's probably every 5 to 6 weeks realistically. Cases are listed with our GI physiologist, and it is minuted and uploaded onto case notes, so it's there like any other MDT. Just a few quick numbers. Because of this talk, I looked back to see at what we've done within it. We've run it since March of this year. We've had 39 cases discussed. We've got 2 hospital sites within our trust. 27 of those cases were patients from surgical referrals, and 12 were from medical consultants, with a real mix of motility disorders and those being considered for anti-reflux surgery. So we considered 26 cases where anti-reflux surgery was something that was being questioned. 7 were agreed for, and 19 felt that the MDT felt in 19 cases they weren't appropriate. And I think this really reflects the 2 talks that we've already had already about the real importance of patient selection in anti-reflux surgery to try and improve your outcomes. So it's just a good opportunity to look back at what we've been doing. I'd endeavour to get involved with your local friendly gastroenterologist. Okay, so what I've tried to do now is I've just pulled 3 cases, each trying to look at a different aspect, all real cases from our MDT. Variety, some are more straightforward, some are more complex. Okay, so the first one is a 26-year-old man. He's a scaffolder by trade, so he's very physical in his job. He's got a normal BMI, previously smoked, makes minimal amounts of alcohol, just vapes now. He describes heartburn, so a real retrosternal burning and regurgitation of acid sort of contents that is worse at night time. He gets a reasonable response to PI and uses Gaviscon at night time particularly as well. He has an OGD, which shows some esophagitis, and then he goes on to have his physiology studies. So Paul's already shown a slide of this, but just to orientate you, if you can see, for those who don't look at them regularly, we've got our upper esophageal sphincter here, our lower upper esophageal sphincter here. Your colours represent the different pressures. The reds, the really bright colours are the high pressure, the blues and the greens are the low pressure. You can see in this case, we've got a swallow, we've got upper esophageal sphincter here, nice opening of that with the appropriate relaxation of the lower esophageal sphincter here, and a lovely, nice, clear peristaltic wave. Obviously, it appears as a diagonal because it's a recording. So this is a snapshot of a recording rather than a play of it now. You can see that you get that subsequent reappearance of the lower esophageal sphincter, and another swallow looks good as well. So I haven't included the parameters on here, but this gentleman's study was completely normed from a motility perspective, which is really helpful when you're thinking about what you want to do with. So next he goes on to have his pH study, which is all we do catheter-based in Derby. We tend to do pH only. We'll only do pH with impedance generally if it's been specifically asked for specific reasons, or in a second attempt, normally, as someone else has previously discussed, looking at regurgitation and to see whether it is volume reflux or fluid that's coming back as well. So I know that as gastroenterologists, we tend to look at acid exposure time a little bit more. So you can see here, this acid exposure time is 11.2%, obviously greater than your 6%, so is positive. And then one thing that I'm really interested in, that's again being reiterated in this, is how does this reflect in people's symptoms? Because we're doing this surgery for people's quality of life and the symptoms that they've got. This gentleman, I didn't include it on the previous slide, but had a Hydrogenated score of 39. And then we've got his symptom indices. So his symptom index, which is the number of symptoms he's had that have been associated, well, the number of reflux associated symptoms versus the number of symptoms he's had is 100%. So every symptom he had was associated with the reflux event. His SSI, which is symptom sensitivity index, which is looking at what's the likelihood that if he's just got a lot of reflux, has he managed to just press it and happen to get onto one of those? It's trying to tease out those people who have a lot of reflux, but symptoms aren't always associated with those. It's 2.2%, which ideally it should be over 10% to be considered positive, but he's only recorded 5 symptoms. Quite a stoical guy, just got on with it, didn't really think he had to record everything that went on. His SAP, which is his symptom association probability, which is trying to predict by a 2-by-2 table whether symptoms are related to reflux, is 99%. So nice and positive for that. So just as the first case we're doing, what would people suggest for this gentleman? Partial response to PPI, would like to explore surgery if he can, and has got this pH and this manometry studies.
Can we ask Professor Vish to comment, please?
Yeah, well, it's a good case. Obviously, you sit with the patient and whether he had any prokinetics or what sort of PPIs, and I would not rush quickly just based on this into surgery as such. And obviously, so those factors would take has to be taken into consideration before I rush into counseling towards so-called surgery. So he hasn't got any hiatus hernia, as I understand, and I have not seen the endoscopy pictures. So obviously, there's no absolute indication for laparoscopic or robotic surgery, but there's also one should consider for endoscopic therapies as well, so which could be TIF or strata. So that's something which I would sort of counsel in detail, explain the options, but I would not rush into any therapy as a first step.
Okay. And Mustafa, would you like to comment on that as well, please? Is Mustafa still there?
Yes, sure.
Yeah, Mustafa, sorry. Yeah.
I got disconnected for 1 minute, but I will go for these patients. I didn't get the gastroscopy finding except the esophagitis. So still for me unclear, hiatus hernia, yes or no, and if yes, how big? And from the clinical aspect and his physiological studies, I will go for anti-reflux surgery.
Okay.
I think so. He didn't have a hiatus hernia at all on his OGD, and actually he was discussed at MDT. He was quite pro-surgery. He found some of the volume regurg, I think, associated with the work he did quite difficult. So surgery was thought to be. He tried quite a lot of medication before to be appropriate. He's not had it yet because this is from March this year, and understandably with COVID and everything, those things have not moved forwards yet.
So I will go if he didn't show any kind of a clear hernia. So I will go for LINX implantation for such patients. It's a perfect patients, young patients, don't have clear hiatus hernia, symptoms resistant to medications. So I will go for LINX.
Okay.
I'll move on. LINX we may mention later because I think it's a really interesting area. Sorry, my mouse is really misbehaving, so I can't just try and, oh, there we go, get my next slide. Okay, so next case, so I've just got 3 in total, so number 2. So this is a 23-year-old male as well. He is an ex-smoker as well, minimal alcohol. He has a normal BMI, and again, predominantly nocturnal symptoms. He describes it as water brash and sort of very much feeling that fluid coming back. some retrosternal burning as well. He is completely responsive to PPI. However, he says he's very young. He's a little bit worried that does this mean he's going to have to take PPI medication for the rest of his life? So he'd like to be considered for the possibility of anti-reflux surgery, although he's not dead set on it. He just wants to know what his options are going to be. Okay. Now I haven't included his OGD. So his OGD showed a little bit of mild esophagitis, no hiatus hernia associated with it. So in this case, I'm going to show the pH studies first, and then I'm going to show his manometry. So on his pH studies, you can see here that he had quite clear acid exposure times 13%, so very positive. A Demista score of 48.05. And again, similar to our last case, he's got a symptom index of 100%, so he's hit a reflux every time he's had a symptom. He's again not recorded lots of symptoms, which is partly explaining why his SSI is down a little bit, but his SAP is positive as well. He's just got the symptoms that I've mentioned before. He's got no dysphagia, he's got no swallowing difficulties, and he never has done, okay, and no other associated systemic symptoms. So this is his manometry study. So you can see here, we've got our upper esophageal sphincter here, we've got opening of the upper esophageal sphincter here, and then we've got 0 peristalsis, just nothing there. You can see it doesn't quite come up in this image, and a bit better here that there is relaxation of the lower esophageal sphincter, and on some later swallows, that was more clear as well. So the software couldn't even calculate a DCI because there was no peristalsis or anything to really capture and to try and look at it. So this is his next part of his manometry, which is multiple repeated swallow, which is a way of trying to see how much the esophagus can deal with, how much the patient can clear. What we would normally expect is after they've had their multiple repeated swallow, when they've swallowed repeatedly here, as you can see at the top, is we should get a nice big clearance wave coming when the esophagus really powers through to try and clear all that liquid that it's had in there, because obviously with lots of swallowing you get your deglutative inhibition going on then. And as you can see in this case, we've had no clearance swallow at all. So there's nothing's happened ever. He's swallowed it fine, it's gone down, he's not symptomatic from anything related to this, but he doesn't have any peristalsis here. So this is a patient who would consider intervention. He's unsure if he's happy staying on a PPI for the rest of his life. However, he is fully responsive to it at the moment. He has no dysphagia at all. So what options do we think we could look at in this man with this aperistalsis?
Well, excellent patient. I do get lots of these sort of complex patients. Number one is young. Number two, obviously, I presume esophageal biopsies must be taken in this patient just to rule out eosinophilic esophagitis. If it's not taken, I would recommend it as a first step. Mid and distal esophageal biopsies at least 8 before we consider any therapeutic. Presuming that he has not got hiatus hernia, presuming that he still wishes to have therapeutic intervention, presuming that he hasn't got eosinophilic esophagitis, first option is continued lifestyle, XYZ, and conservative treatment based on the pharmacotherapy as he is responding well. The second one is obviously, and I do have done stratas where you just strengthen the lower esophageal sphincter zone endoscopically. This seems to work, and most importantly, it would not give or associate with any iatrogenic or procedure-induced dysphagia in these patients. It's a $1 million question to answer any one of us. What proportion of this absence of peristalsis is due to reflux or due to innate esophageal muscle problem? It's very difficult. I don't think any one of us, even as a scientist, can answer that. And obviously surgery should be the last test option, and I think all of us will crash and they will become lifelong surgeons' friends if we do any of these operations. In the absence of hiatus hernia, if they've got hiatus hernia, of course you can repair hiatus hernia with probably anterior wrap, which I have done a few patients, but in the absence of it, I would not recommend surgery with any sort of wrap unless surgeon is 59, is going to retire in 1 year time. That's me.
And I think the reason I included this case is it's a real case from our MDT, and it is a question that's coming up increasingly frequently as we do more manometry, and we're finding more motility disorders. And I think Paul and Balaji have already touched on it. There is no clear answer. The data, the retrospective data out there is very mixed. There does seem to be perhaps a suggestion that if you don't have any preoperative dysphagia, you are less likely to get dysphagia after surgery. But again, it's not clear, and I'm not a surgeon, so I'm not the one who's having to do the operation. So it's very easy for me to sit there and say what I think without being the one at the end of things. One thing that was proposed, you've obviously mentioned stretta, and someone mentioned links area. There was a proposal within RMDT where the links could be tried if someone was very keen for an intervention, because it's easily taken down, so it's easily reversed. Whether that is appropriate, I don't know. It's interesting to hear what everyone else thinks.
No, links is contraindicated with this manometry. Of course, you can do links for anybody, but that's not an issue. So although I don't I won't propose links for these sort of patients, no, just because it's reversible.
I think Mustafa, you're raising your hand.
Yes, yes,
Yeah.
it's very challenging, complicated patient. Really very difficult and complex to manage it. We have to discuss with him. I think if in the situation and having such patient, I had it once, of course, links and any rep is contraindicated, clear 100%. We don't have to try it, because as she said, we will have more dysphagia after the operation. As we saw, it's very difficult to get the patient satisfied, because he is not responding very well, or he is responding, sorry, to PPI, but he don't like to take a PPI for a long term. So I will not operate this patient, and if he is satisfied with his medical therapy, so I will leave him with the medical therapy. And try to adjust the doses, and I will not operate him, because I will not reach the satisfaction of these patients.
And
Yeah, Balaji, thank you very much, Mustafa.
That's interesting. I mean, this is once again, it's not an infrequent visitor sort of thing into our MDTs. I think the clear thing here is counseling. It's counseling the patient on what he has and what our hesitation is. I mean, we've all, I'm sure all of us have operated on a similar group of patients. I have operated on a few of these patients. I scare the hell out of them, but they are in a stage of desperation. I don't operate on them straight away. I leave them for a couple of years, carrying on with medications. They keep coming back, and you keep explaining to them. And I distinctly remember a patient with complete dysmotility or aperistalsis, bad reflux, excluded all the connective disorders bit, with dysphagia, and she was desperate, sensible one. The important thing is you must have a sensible patient. And 2 years down the line, I did a partial fundoplication, scaring everything out of her, and she was ready to accept dysphagia because her symptoms were so bad. And after surgery, interestingly, all her reflux went away, and the dysphagia didn't get any worse, and she's a happy patient. So I wouldn't necessarily throw away surgery out of the window, but I think the key is counseling, discuss with the patients, scare the hell out of them, drag it on, and at the end of the day, some intervention. I'm not sure whether it's stretta or links or a fundoplication. I mean, we've got three different, for example, Vish is an expert in stretta, and understandably, I would say this is where we call the surgeon of excellence bias. He's a little bit biased towards stretta because the results are great. I mean, I don't have any experience with stretta. I would probably send some patients to Vish, but I'm a little bit not on the same thing. And we've got a links expert there, but I wouldn't necessarily throw out intervention, although not at this stage. So there we've got three different opinions.
Which is why it's hard, because there's not a right answer, is there?
But that's where the MDT comes, isn't it?
Exactly.
And it's explaining to the patient. If you get the expectations down, undersell, I think you have a lot of happy patients.
What about Paul? Paul, what do you think?
Oh, you're muted.
Paul,
just while Paul's coming, I can tell you the patient actually decided, because he was totally responsive to PPI, he was just going to stay on his PPI and left it as that.
Oh, sorry, Paul's mute's not working.
Okay, so one more case. So this is a 61-year-old man. He's had a previous fundification, which was a full wrap a couple of years ago. He's come back because he's still got some symptoms. His pre-op symptoms were retrosternal pain. He said there were some lying down and a sour taste in his mouth. He's got a partial response to PPI, so a little bit better, but not fully. He's a non-smoker, minimal alcohol again, and then he has a 4-centimetre hiatus hernia reported on his OGD. And I haven't noted if he had an esophagitis at all. Sorry, let me get to my next slide. Okay, so these are his pre-operative manometry images. So these are his single swallows here. So you can see he's got a little bit of fragmented peristalsis here, but not too bad. He's got clear opening of his lower esophageal sphincter and reasonable motility. So his IRP was normal, looking at the pressure within that. And his distal contractile integral from here was nice and normal at 802. This is where he's completed a multiple repeated swallow for us, and we can see there's no peristalsis here, as you would expect while you're doing that multiple repeated swallow, with a pretty good clearance swallow coming up here, a little bit fragmented as well, but nothing too dramatic. He's then had his pH studies, so he's got an acid exposure time of 6%, so just hits the number for being significant and abnormal. He's got a Demeester score of 15.2, so just over. His symptom indices are a little bit mixed. His SI index is 33% and his SSI is 5.5, so both down a little bit. His SAP is positive at 97. He's very, very pro-surgery and he really wants to have something done, so he did have surgery. He describes very quickly post-operatively that he gets some discomfort. So he says, well, from the records that I have, those symptoms came back quite quickly, just like he had before. Some dysphagia as well, although from what I can gather, dysphagia wasn't the particularly predominant symptom for him. And the words that are used in the e-case notes that we have is that it's just like what I had before surgery. So he has some more manometry. So you can see this is post-op, it's after he's had his full wrap, and you can see that already the lower esophageal sphincter area is higher pressure. He's got an IRP of 18.3. So it's up obviously from normal for someone who's not had surgery. Now, I certainly don't know of an absolute value that you look for necessarily post-operatively with wraps and things. We've got ranges, we've got things that you can look at. It's very much dependent on people's individual cases of dysphagia, but this is up a little bit. He's also got a little bit of fragmented peristalsis as well. And he hasn't got a brilliant clearance wave here. It's sort of a little bit different to what he had before afterwards. Didn't have any solid swallows. He does have a barium, which looks totally normal, all right, all good. He thinks he's still got reflux, I think, from what the letters and things describe. So he has the repeat pH studies, which show that actually his acid exposure is 3.8%, and his Demeester score is 10, so both are normal, and his symptom indices are way down. So he's hardly hitting anything with any of the symptoms that it's recording with any reflux events. So this gentleman is saying he has a sour taste in his mouth, he has retrosternal pain, things that he associates with reflux, with a little bit of dysphagia that isn't particularly predominant in him, and he's not losing weight. What would you offer or think about in this gentleman?
Paul, do you want to answer on that one at all? Let's give us a lovely talk on revisional surgery.
Yeah, thanks a lot, Bridge. I would suggest that maybe this is one of those patients that's got a slightly over tight wrap, and maybe they're experiencing that degree of the sort of supragastric reflux, where this is sort of the pooling of fluid that tastes nasty in their mouth, and it's not actually true reflux at all. If it's early on in the history of their fundoplication, I would ask them to be patient, particularly if the barium's normal. I don't think there's any value in esophageal dilatation in this patient, but I would try and their weight is maintained, so I don't think you need to rush in to do anything. And I think time would be a great healer for them. I don't know what other people think.
Yeah. So anybody else would
Yeah,
differ?
I can,
Yep.
I
Yeah,
would, I would
Balaji, please.
completely be in complete agreement with Paul. No questions at all. Stay out of him. It would get better. And the symptoms are likely related to the supragastric reflux. If we want objective evidence here, maybe an impedance would help, because that would show up those, intraesophageal to reflux is not coming from the stomach. It might help more for objective evidence rather than treatment. But otherwise, with regard to treatment, in complete agreement with Paul.
Great.
I think it's really important points, isn't it? It's looking at symptoms but not wanting to intervene too soon and cause more problems or other problems when time may heal things. And that was what was done in this case. I think he was intervened with, and certainly dysphagia improved and things. He was still quite, I think, fixated that reflux was a problem, but as you say, it's not true reflux, where impedance would be helpful because you could show that movement, couldn't you, from the stomach to esophagus, or see if it was just located within your esophageal channels only. So yeah. And I think
Emily,
that is...
there's a question. I think if I could ask you from one of the person attending, I think he's Dr. Arishi. Any role of gastric emptying studies in this case?
I think probably not. His dysphagia will most likely be related to his RAP, and unless there was you were worried about volume coming back, which would be very difficult past the RAP, I don't think that would necessarily help. He could be someone with some overlying IBS and things like that as well, or someone who's a little hypersensitive to any changes. So I don't think I do gastric emptying, but I may wonder if hypersensitivity is playing a role. And sometimes in these cases, and we've discussed it, whether using things like amitriptyline as a visceral analgesic, it could be helpful if pain or discomfort are a bit more predominant and disproportionate for what we'd expect from the objective findings here.
Okay, thank you very much. I think that yeah, no, Emily, that was an excellent presentation. I must say, I mean, the MDT has helped us definitely a lot in coming to decisions for some of these difficult patients. So thank you very much. It was a lovely presentation, Emily. Vasha, do you want to?
Yeah, we have a few questions that we haven't quite answered. I'm not sure they. I think one of them was to do with management of hiccups, or I think the question was more about why people might have hiccups following surgery, and if anyone's had previous experience of this, particularly toupees. I think the question mentioned. Balaji?
Gosh, I'm stuck here. Well, I mean, hiccups, the symptom, probably there is an element of diaphragmatic irritation, isn't it? And I presume we can try all medications and sit tight and hopefully it'll get better. I'm not aware of prolonged hiccups, needing anything further than sitting tight and medications. It might be due to a bit of diaphragmatic irritation in the immediate post-operative period due to sutures, hematoma, fluid collections. Not sure, but nothing to intervene, I suppose, or specify any specific cause for it. That's all I can offer, I'm afraid. Anyone else might have more experience?
I agree also 100%. I think it's phrenic nerve irritation, post-operative, and we don't have a lot to offer for such patients except to be patient.
Okay.
Yeah, thanks for that. We also had a question about how you would manage patients with iatrogenic Pervs, particularly after complex revision surgery, if anyone had to deal with that before. I thought maybe
the best way to manage them is not to cause them in the first place.
Yeah, true.
If you do cause them, identify them at the time of surgery and stitch them up. And if you stitch the hole up, you can just carry on with your procedure. It's not an issue. The most difficult problem is if you cause a thermal injury and they develop a delayed leak or perforation when they're at home eating their burger and chips a few days later. I think that's the biggest problem. And then particularly if it's a patient that's a tertiary referral and they get sent to another hospital, then they can run into great difficulties. And they can end up dying from those sort of complications if delayed. So the key really is early diagnosis and early treatment.
Yeah, just I want to add, any complex, especially if you suspect iatrogenic injury, not knowing the consider per-operative endoscopy and ear leak test or dye test or whatever, especially when you're doing college gastroplasty or some sort of additional part of the surgery, in a very complex revision surgery. That's very important to bear that in mind. As Paul says, make the first operation the best, or first revision operation is the best. So that's so important. But again, going back to management, if they come back to the post-hospital, you usually conserve them with nil by mouth and enteral nutrition, antibiotics, etc. I don't think, very rarely we have to re-intervene, except sometimes radiologically. So, but if untimely intervention can associate with lethal complications, which we said earlier.
Thank you. And also a quick mention of an ongoing study in the UK called the Aerostudy. I'm sure many people are already involved in it, but one of our participants has put up a message about it, Marion Holliman. If you aren't already involved and you would like to get involved, I think I've just put the address here, aerostudy.co.uk, for a quick questionnaire about current practice. I think she'll appreciate any support. I mean, we are a collaborative group, so I think she would appreciate any involvement.
I think
that's all the
certainly.
questions.
Yeah, I think so. Yeah.
Yeah.
I think that's yeah, perfect. I think we can. We are already quite late, so we can bring the meeting to a conclusion. So I'd like to thank everybody who attended today. Thank you, Balaji, and thank you, Paul, for excellent talks. And it was really, I think thank you for sharing all those pearls of wisdom. I'm sure we have learned a lot. Sorry, Vasha, do you want to say something?
I had another question, if that's okay. I think particularly for people who do the endoscopic treatment, whether they had any advice about patient selection for endoscopic treatments like Stretta or TIF.
So shall I just, so I think I've already agreed with Professor Vishwanath. We'll have a specific talk just on endoscopic treatment for reflux. I think it's a whole topic on its own, which I'm sure everybody will agree. So it won't do justice to the topic, just having a quick answer there. So if that's okay, hold that, and I'm sure we'll have in the next a few months a topic on endoscopic treatment for reflux. Is that okay? And thank you so much for the panels. Thank you, Professor Vish. Thank you, Emily, and thank you, Mustafa. Especially, when you're away on holidays, you attended the meeting. Really appreciate that.
Thank you. Thank you.
Thank you all.
Thanks for the invite.
I'll see you all again.
Thank you.
Thank you so much.
Fantastic.
Take
Bye-bye.
care.
Thank you.
Bye-bye.
Thank you. Bye. Thank you.
Bye-bye.
Thank you. I think, Vasha, we can leave as well. I'm going to end. Thank you so much. Thank you so much for your help today. It was excellent. Thank you.
Take care. Bye-bye.
Thank you. Bye. Kamal, thank you. I don't know if you're still there. It's probably there. Yeah, it's fine. Yeah, thank you.
Yeah, good night.
Bye. Good night.
The question about where it's recorded, do we have a link for that? Or
yes, what I'll do is I will upload it get it uploaded. There's a website. I think it's mainly done by I think Alessandro, who helps you with that. Yeah, so I'll get it uploaded, and then I'll share it on social media, and we could email everybody as well on the TUGS Google group. Yeah.
Okay, fine.
Okay. Thanks, Vasha. Thank you. Bye. Good night.